There's something I need to tell you, and it's been keeping me up at night. I'm a surgeon. For the last 25 years, I've stood in operating rooms performing procedures that save lives. But here's what haunts me. There are 5 surgeries, 5 common operations that I do regularly, that I would never, under any circumstances, allow my own parents to have. Now, before you think I'm being overdramatic, let me be clear. My mother is 76, my father is 80, and just 8 months ago, my dad faced one of these exact decisions. What we chose shocked his doctors. But why we chose it could be the difference between your parent living independently or never coming home from the hospital again. I'm not going to tell you what those 5 surgeries are just yet. I know that's frustrating, but stay with me. Because if I just gave you a list right now, you'd miss the critical context that separates life from death. You need to understand what happens behind those operating room doors, what the research actually shows, and what we surgeons whisper to each other but rarely tell our patients. In the next 9 minutes, I'm going to walk you through exactly what you need to know to protect someone you love. Let me tell you about Helen Martinez. She was 73 years old, a woman who walked 3 miles every morning, tended her rose garden, and babysat her grandchildren twice a week. Last November, she slipped on her bathroom floor and fractured her hip. It wasn't even a bad fall. She called 911 herself, stayed completely alert, and arrived at one of our city's top-ranked hospitals within 90 minutes. I wasn't Helen's surgeon, but I reviewed her case because I consult on geriatric surgical outcomes. Everything looked perfect. Her pre-op labs were better than most 60-year-olds I see. Strong heart, excellent kidney function, no diabetes. The orthopedic surgeon was someone I'd worked with for years, truly skilled. The surgery itself? Textbook perfect. 2 hours, 0 complications, hardware placed flawlessly. When Helen opened her eyes in recovery, she even joked with the nurses about missing her morning walk. The surgery was a complete success. But here's where the story takes a turn that I see over and over again, yet families are never warned about. On day 2 after surgery, Helen's daughter noticed something odd. Her mother asked what year it was, then asked again 10 minutes later. The nurses brushed it off. Post-operative confusion, they said. Totally normal. It'll pass. By day 4, Helen didn't recognize her own daughter. She became agitated, trying to climb out of bed, convinced she was late to pick up her grandchildren from school. This wasn't confusion. This was post-operative delirium, and it triggered a catastrophic cascade. Because Helen was confused, she couldn't participate in physical therapy. Because she wasn't moving, she developed pneumonia. The pneumonia required powerful antibiotics. The antibiotics destroyed her appetite and caused severe digestive problems. She lost 18 pounds in 3 weeks. What was supposed to be a 5-day hospital stay became 7 weeks. When Helen was finally discharged, she didn't go home to her roses and her grandchildren. She went to a nursing facility. 9 months later, Helen is still there. The hip surgery was technically successful. The bone healed perfectly. The hardware looks great on x-rays, but Helen never returned home. She lost her independence, her morning walks, her garden, and according to her daughter, the spark in her eyes. The surgery worked, but Helen's life was destroyed. And here's what makes me furious. This outcome isn't rare. This isn't an exception or bad luck. This is a pattern I witness constantly, and it's time someone talked about it honestly. Now you might be wondering, how could this happen? Helen had excellent doctors, a top hospital, a successful surgery. What went wrong? The answer is going to make you angry, and it should. Nothing technically went wrong. The system worked exactly as designed. That's the problem. Our surgical protocols, our hospital procedures, our recovery expectations, they're all built around younger patients. What works brilliantly for a 50-year-old having hip surgery can be catastrophic for someone over 70. And most of the medical establishment either doesn't realize this or won't admit it publicly. Let me break down the science that every surgeon knows but rarely discusses with elderly patients and their families. First, anesthesia affects older brains fundamentally differently than younger brains. A 2023 study from Johns Hopkins tracked over 12,000 patients over age 70 who underwent major surgery. They found that 42%, nearly half, experienced measurable cognitive decline afterward. Not temporary confusion that clears up. Actual cognitive function loss that persisted 6 months later. The anesthetic drugs we use accumulate differently in aging brains. They interact with medications seniors are already taking. They disrupt neurotransmitter systems that are already fragile. Every additional hour under general anesthesia after age 70 increases the risk of permanent cognitive problems. But how many anesthesiologists discuss this before surgery? Almost none. Second, the hospital environment itself is toxic to elderly patients in ways we're only beginning to measure. Think about what a hospital is. Fluorescent lights blazing 24 hours a day, constant noise from machines and overhead announcements, people waking you every 2 hours to check vitals, unfamiliar bed, unfamiliar sounds, complete destruction of normal sleep cycles. For a 45-year-old, this is annoying. For a 75-year-old, it triggers a catastrophic cascade. Your internal clock gets disrupted. You can't distinguish day from night. Disorientation becomes delirium. Delirium becomes agitation. Agitation requires sedatives. Sedatives cause more confusion. The cycle spirals downward, and once it starts, it's incredibly hard to stop. Third, immobility after surgery destroys elderly bodies at shocking speed. Research from the American Geriatric Society measured muscle loss in hospitalized seniors. They lose between 2 and 5% of their muscle mass every single day they're bedridden. A 50-year-old might lose 0.5% daily and rebuild it quickly, but a 75-year-old losing 4% daily for 2 weeks, that's nearly 40% of their muscle strength gone. Once that muscle is lost at that age, it's extraordinarily difficult to rebuild. You're not just recovering from surgery, you're recovering from the catastrophic physical decline caused by the recovery itself. In my practice, I see patients come in walking independently and leave unable to stand without assistance, not because of the surgery, but because of what the hospitalization did to them. Fourth, elderly patients experience what we call the cascade effect. One complication triggers 3 more. You have surgery, you develop delirium. The delirium makes you immobile. The immobility causes pneumonia. The pneumonia requires antibiotics. The antibiotics cause digestive issues. The digestive issues cause malnutrition. The malnutrition impairs wound healing. The poor wound healing causes infection. Round and round it goes. I've seen patients admitted for a routine procedure and leave 10 weeks later having survived sepsis, pressure ulcers, hospital-acquired infections, and blood clots, none of which were complications of the original surgery, but all of which were triggered by it. And fifth, recovery capacity after 70 is fundamentally different. This isn't about being old or weak. This is pure biology. Your mitochondria don't produce cellular energy the same way. Your immune system doesn't respond to surgical stress the same way. Your hormonal environment doesn't support healing the same way. A 50-year-old body sees surgery as a challenge to overcome. A 75-year-old body sees surgery as a life-threatening crisis and responds by going into survival mode. Sometimes the body never fully comes out of that mode. So now you're ready. Now you understand the context. Let me tell you the 5 surgeries I would never let my parents have, and more importantly, what the alternatives are that most doctors never mention. Number 1, hip replacement surgery after age 75. Now, before orthopedic surgeons flood my comments, let me be specific. I'm not saying hip replacement is never appropriate. I'm saying the risk-benefit calculation changes dramatically after 75. A 2024 study from the University of Toronto tracked 9,000 hip surgery patients over 75. Within 1 year, 31% had not returned to their previous level of function. 18% were in nursing homes or long-term care facilities. The surgery itself has a 96% technical success rate, but the life impact success rate is far lower. Alternatives: intensive physical therapy with a geriatric specialist, advanced pain management protocols including targeted injections, mobility aids like walkers or canes, strategic home modifications, and sometimes accepting reduced mobility with an adapted lifestyle rather than risking catastrophic decline. Number 2, emergency colectomy for diverticulitis or bowel obstruction. The mortality rate for emergency colon surgery in patients over 70 ranges from 15 to 28%, depending on the study. Even for survivors, the recovery is brutal, temporary, or permanent colostomy bags, chronic digestive complications, months of recovery time. Alternative approach: aggressive medical management first, IV antibiotics, bowel rest, drainage of abscesses if present. Many situations that feel like emergencies can actually be managed conservatively if you find the right specialist. Always get a second opinion from a geriatric gastroenterologist before consenting to emergency colon surgery. Number 3. Perforated ulcer repair in frail patients. Perforation is serious. I'm not minimizing that. But the decision isn't as black and white as surgeons often present it. Patients over 75 with perforated ulcers who undergo surgery face mortality rates between 25 and 45% in most studies. The surgery is extremely high risk, the recovery is devastating, and outcomes often involve prolonged ICU stays. Alternative: in select cases, specialized centers are having success with conservative management, aggressive IV antibiotics, drainage procedures when possible, intensive monitoring. It doesn't work for everyone, but it's worth discussing before jumping straight to major surgery. Number 4. Small bowel resection for intestinal obstruction. Similar to colectomy, this surgery involves removing diseased sections of small intestine. Technical success rate is good, but functional outcomes for seniors are often poor. Post-operative ileus, where the bowel stops working, prolonged recovery, nutritional complications, high risk of requiring additional surgeries. Alternative: many bowel obstructions can be managed with bowel rest, nasogastric tube decompression, careful monitoring. Obviously, some require surgery, but not as many as currently receive it. Push hard for a conservative management trial first, unless there's clear evidence of dead bowel tissue. Number 5. Appendectomy in patients over 80. The mortality rate for appendectomy jumps dramatically after 80, from less than 1% in younger patients to 6 to 10% in patients over 80. Why? Elderly patients often present late, the appendix has already ruptured, and they develop severe sepsis. Here's what most people don't know. In select cases of uncomplicated appendicitis, antibiotics alone can work. A 2023 Scandinavian study showed that approximately 65 to 70% of uncomplicated appendicitis cases in elderly patients resolved with antibiotics alone, avoiding surgery completely. This is controversial, and it doesn't work if there's perforation or abscess, but it's an option worth knowing exists. Now here's your action protocol. Save this information, share it, bring it to doctor's appointments. Step 1. Before any major surgery, ask your surgeon to calculate your frailty index score. This validated tool predicts surgical risk in elderly patients. It takes 5 minutes and gives a numerical score. If your surgeon doesn't know what this is, that's a major red flag. Step 2. Request cognitive baseline testing before surgery. Simple tests of memory and processing speed done before anesthesia, then repeated at 6 weeks and 3 months after. This documents any cognitive decline and might change your decision about whether surgery is worth the risk. Step 3. For any recommended surgery, specifically ask, what are the non-surgical alternatives and why are we ruling them out? Make the surgeon explain why conservative management won't work. If they say there are no alternatives, get a second opinion from a geriatric medicine specialist, not another surgeon. Let me bring this full circle. Remember I told you my father is 80? Last year, he developed severe spinal stenosis. A surgeon recommended fusion surgery, a 5-hour operation with months of recovery. My father asked me what I thought. We sat down and went through everything I've just shared with you. We calculated his frailty index. We discussed his priorities. He wanted to keep working on his vintage car, to keep playing cards with his buddies, to maintain his independence and his sharpness. We got a second opinion from a geriatric rehabilitation specialist. She recommended intensive physical therapy, epidural injections, and lifestyle modifications instead of surgery. My father chose that path. It's been 14 months. He still has stenosis on the MRI. But his pain is manageable. He's still working on that car. He's still playing cards every Thursday. He's still himself. Would surgery have given more pain relief? Maybe. But at what cost? He made an informed choice based on his values, not just on what the first surgeon recommended. That's what I want for you. Not to avoid surgery at all costs. Sometimes surgery absolutely is the right choice. But to make informed decisions based on complete information, realistic outcome expectations, and your own priorities. To know that alternatives exist. To understand that what works for younger patients might not be right for someone over 70. To have permission to ask hard questions and demand honest answers. The goal at 75 isn't just to live longer. It's to live better, with independence, with dignity, with the ability to do the things that make life worth living. Sometimes surgery supports that goal, sometimes it destroys it. You deserve to know the difference. Start small. Commit to having this conversation with any elderly family member who might face surgery in the future. Print out those 3 steps I gave you. Bring them to the next doctor's appointment. Don't be afraid to be the patient or family member who asks difficult questions. You're not being difficult, you're being wise. If this was helpful, hit that subscribe button so you don't miss future videos where I share what we doctors know, but don't always tell patients. The real conversations we have among ourselves about what we do for our own families. Thanks for watching. I'm Dr. Mark Westfield, and I'll see you in the next one.